Welcome to our Global Public Health Challenges and Opportunities Insight from the Experts webinar series. This is the second week of our 4-week series, which is happening the same time each week. And we really value your participation in these sessions, so please feel free to make any appropriate comments throughout the talk in the chat function. And you can also use the Q&A function if you've got any questions, and we'll take Q&As after the talk. Please note that the session is being recorded and it will be made available online on the Brunel YouTube channel next week. And today we're really very lucky to have Professor Ravi Mehrotra to present his talk on challenges in breast cancer control in India. Professor Ravi Mehrotra is the CEO and Programme Lead of the India Cancer Research Consortium and an adjunct professor at Brunel. He is a member of the Scientific Council at the World Health Organization's International Agency for Research on Cancer. Earlier, he led the Indian Council of Medical Research's National Institute of Cancer Prevention and Research, as well as the WHO's Framework Convention on Tobacco Control, Global Hub on Smokeless Tobacco. He's interested in translational clinical research in cancer, tobacco control, and implementation science. So we're really very lucky to have Ravi here today. So Ravi, we're very much looking forward to your talk. Take it away.
Great. Thank you, Emma Norris. That's so kind of you. And thank you for the very kind introduction. So today, I'm going to talk about some of the challenges that we face in India and actually in many other lower income countries, which is paraphrased as LMICs, working in breast cancer control. So as I'm sure many of you are familiar that very recently, in the last few weeks actually, on the World Cancer Day, on the 4th of February, it was announced that breast cancer now is the single largest killer of all cancers in the world. It used to be lung cancer till about a month ago, but the most recent IR Globocan 2020 results that were released very recently by the WHO actually confirmed that breast cancer is now the leading killer, not only in the developed, but also in many parts of the developing world. As you can see from this Time magazine cover, it has been for quite some time that breast cancer has been spreading around the world. So it is a matter of concern for many, especially oncologists, cancer epidemiologists, and public health officials and researchers around the world. This is a map which shows the leading causes of cancer death in women. And as you can see, the orange color is breast, and cervix is, that is the lower part of the uterus, that is in yellow. So with the vast majority of Asia, many parts of Europe and Northern Africa, as well as Southern America, the breast cancer seems to predominate. While in relatively smaller part of the world, especially cervical cancer, especially the lower parts of some parts of Africa and South America, and occasional yellow you can see in Asia is the cervical cancer. So many high-income countries routinely screen for these cancers, but in most of the lower middle-income countries, we find that screening is just not done. And many cancers come up at late stages instead of being found at the very, very early part when they are developing. So now we're talking about breast cancer in the year 2020. These are the latest Globocan figures from the International Agency for Research in Cancer from WHO. And as you can see, a little more than 2 million cases of breast cancer are seen worldwide, and which is roughly about 12% of all cancers. Breast cancer, unfortunately, is more than 684,000, but practically 700,000 cases, and accounts mainly around the world for practically 6.5% of all deaths. So incidence-wise, it is 11.7, while number of deaths or morbidity is about 7%. And as I was mentioning earlier, for the first time, the female breast cancers have become the most commonly diagnosed cancers. surpassing lung cancer, especially in deaths. And especially it is also seen, it is surpassed cervical cancer, which used to be the number one cancer for females and lung cancers for males. So obviously it's a burning problem, not only in the LMICs, but also in the more developed parts of the world. So when we talk about India, the age standardized incidence ratio stands at about 48 in the world, while in South Asian countries, including countries like Bangladesh, India, Pakistan, Sri Lanka, Nepal, and so on, it is little less. It's about 41 per 100,000. So overall, if you look at the number, they are relatively less as compared to the world. But you must remember, this is one of the most populated part of the world. So the actual number of cases is fairly high. India itself has little more than 1.35 billion people. Right? And breast cancer incidence for India is about 178,000, which accounts for 13.5% of all cancer cases. While breast cancer in women, if you look at all the cancers in women, roughly about 1/4, that is 26% of all women cancers happen in this country. So I will not bother you to take you too many statistics because it is all there on the screen. But at the same time, what I would like to talk about is that every 4 minutes, an Indian woman is diagnosed with breast cancer, of which at least one woman dies every 13 minutes. Now, these are obviously approximations. But if you want to really look at the number, about 1.4 million new breast cancer cases, roughly about 50,000 deaths from breast cancer happen. So nearly, if you look at the difference, roughly about 30 to 40% of women die of their breast cancers every year. So the mortality is fairly high when you compare it to the West, where nearly about 70 to 80% people live at the end of 5 years. Here you will find that not more than half would live. Sorry. So when you look at the 5-year survival rates, they dramatically decline with the higher stages. For example, as high as 93% in stage 2, where it comes down to really a quarter, that is 22% when you are diagnosed in the late stages. And more than half of the patients from the lower income household, that is people who find it difficult to make two ends meet, spend more than 20% of their annual household expenditure on breast cancer treatment. So unfortunately, because the insurance schemes and the private setup, and now recently we have introduced the government universal health care, they are just about taking off. So one of the major causes of catastrophic financial expenditure and out-of-pocket expenditure is a cancer diagnosis. Because breast cancer is among one of the leading causes of female cancers, obviously it has the lion's share, so to say. So if you look at the graphic on the right side, you find that, as far as the percentage of people who live 5 years, it is obviously very high in the early stages of 1 and 2, and then it comes down dramatically when you are coming to the stage 4. So one of the major issues is lack of awareness, of lack of screening, as well as lack of diagnostic facilities, which I'll be touching on briefly as we go along. The good news is that India has a very young population matrix. These are the figures from a few years ago, and you find that the vast majority of the individuals are less than 25 years of age. As a matter of fact, you look at the stats, about 25% of, practically 50% of the population of the country is less than 65% of the population is less than 25 years of age. So although as far as the LMICs are concerned, 62% of global cancer mortality occurs in LMICs. However, when you look at the global cancer funding in terms of research, in terms of care, not even 5% is directed toward these countries. So there is a gross mismatch between the extent of the problem and the numbers that happen in this part of the world. And the same is true for India. But the fact is, because we have such a young population, the numbers are relatively lower. However, having said that, as the population age is increasing, our number of people who are there in their 70s or 80s or even 90s is going up dramatically. So this pyramid has changed over the last 15, 20 years, and is probably changing very fast due to better healthcare that is provided to our people. So one expects that the number of cases of breast cancer is going to increase dramatically in the years to come. I mentioned lack of awareness. So I am sure you are familiar with the various aspects of breast cancer symptoms and signs. So many people are, many people are not aware that there's a lump in or thickening of the breast, a change in the size of the shape, redness or a rash around the nipple, constant pain. And these are standard signs of breast cancer. And many of them are not really aware that this could be a breast cancer. There is a tendency to delay and to keep waiting till it goes away. Unfortunately, sometimes it doesn't go away. So the problems that are associated with the late detection are either no knowledge or very little knowledge of the warning signs. There's a patriarchal society where males are still dominate, and quite often the lady of the house would ask the male to accompany her, and that may not be possible, especially in the rural areas where they may be busy in the fields or just not bothered, or maybe working as migrant labor or as a immigrant to some other country, may not be free to come to with the lady, and the ladies find it difficult to go to the doctors on their own. In addition, there is social stigma and embarrassment, because the female breast is considered to be a very private organ of the body, obviously, and they are not happy to show it to a male medical worker or even a male doctor. And you might find in certain areas that female surgeons or female doctors are just not available. So they quite often just consult among themselves. And since, especially at the younger age, most of the breast lumps are benign, even a cancer may be mistaken, and people will just hang on to it, hoping it'll go away. And in addition, there are household responsibilities, for example, work in the kitchen or working with in the fields or some other responsibility, or the elders in the family are not comfortable for the lady to go, or maybe hesitant that why should the lady should go to a doctor in the first place, because initially over the first few months, quite often there are no symptoms and hardly any signs. And of course, unfortunately, especially in the rural areas, there is a less developed concept of self-care. So the lady of the house generally would look after everybody in the household, including the children, the husband, and if possibly the in-laws or relatives staying with them, but they would give least importance to their own body. This is changing now as we talk, but it's still very deep-rooted beliefs in the uh, rural and semi-urban areas are still a problem. So you can understand that all these could lead to a late detection of breast cancer. If they come late, there are obviously chances of fewer successes there. So now I want to talk about young female breast cancers. And this is a slide from my friend, which I have borrowed, Dr. Bhavna Sirohi, who was earlier in the UK, and now she's working at the Apollo Proton Center in Chennai. And she very kindly let me have the slide. So the causes of increasing incidence in younger women, first of all, is the increasing population, a reduction in mortality from competing causes. For example, infectious diseases are right down. There's a transition in the cancer spectrum, in the sense that lifestyle cancers are increasing and infections related cancers, including cervical cancer, is going down. And also there's increased screening for, especially in the private sector. For example, if you talk about the IT sector in Bangalore or various other corporates, they are actually helping with screening. Similarly, there's a changing social and cultural practices. Many more women are getting educated, they are working in the offices, getting married late. And similarly, there's an energy imbalance. When you know there's a higher per capita calorie intake, especially in the middle classes and the rich people, reduced physical activity in the urban areas for people not exercising enough because they're not working out, and obesity is a cause. And obesity, as we all know, is a cause for breast cancer, especially in the postmenopausal age group. The number of women suffering from breast cancer uh, is higher in the cities, so 1 in 25 might possibly get breast cancers compared to nearly double, that is 1 in 60 in the rural areas. Similarly, when we talk about young women with breast cancer, quite often 50 to 60, that is more than half, are detected with locally advanced breast cancer or metastatic, that is spread disease. There may be a misdiagnosis at the primary level, which may unfortunately result in delay by 3 to 4 months. And of course, I mentioned about social stigma. Similarly, in the case mix, there is a proportion of triple negative breast cancer, that is with the number of the markers, that is the biomarkers like the estrogen progesterone receptor or the HER2/neu are actually negative, and these have a much worse prognosis as compared to hormone positive breast cancer. So the number and percentage is about 30%, which is nearly double what you see in many developed countries. Similarly, worldwide, especially in the developed countries, the postmenopausal breast cancers are much higher. However, in the LMICs, including India, nearly half these cancers could be premenopausal, that is before the woman achieves menopause. Genetics and oncofertility, for example, can you do a biomarker study? Can you actually see which of the women who are more prone to develop breast cancer either are not discussed by the physician or are just not available, or they are too expensive? As you possibly know, between 5 to 10% of all women who develop breast cancer have it running in the family, in the sense the immediate family, for example, their mothers, sisters, or aunts would have had breast cancer too. But the vast majority, 90% plus, do not have any family history, so they are not genetically attained. Similarly, talking about treatment, as you know, chemotherapy, that is anti-HER2/neu, which is a hormone receptor antibody, is access is just about less than 10%. Mastectomy, which is removal of the breast, is generally done, it is more than 80%, and reconstruction as well as the breast sparing surgery is available at very few setups, so not even 10%. These are delays and problems that happen in the young women with breast cancer in countries like India. So these are some of the cancer startups, and I will not take you through all the details, but if we have startups in the country, especially based in Bangalore or Bombay, in parts of the country, we're like Niramai, which is looking at machine learning and big data analytics to develop low-cost diagnostics for breast cancer. Similarly, you have OncoStem, which is doing a multi-marker prognosis and to give a specific tailor-made solution. You have the breast light made by the UE Life Systems, which is again a no-touch breast scan. For treatment, you have these 4-5 companies. With the one that it is specific I talk about is the CanScript from Mitra Biotech. It looks at cost-efficient personalized care. And similarly, for consultation, there are companies like Navya, which looks at the Tata Memorial Center and other setups with you can get an online consultation, and another organization called Tumor Board. So there are a lot of new things that are happening using IT and artificial intelligence to help people get an early diagnosis and hopefully better care, which is personalized rather than one size fits all. So just to recap, what are the challenges in breast cancer care as far as India is concerned? Sometimes lack of radiotherapy machines, for example, they're just about 1,300, while are required, but just about half that number is available. Trained oncologists, most of the facilities are focused on the major urban centers and the major cancer centers of the country rather than the smaller cities or rural areas. Huge number of patients, so it's difficult to actually spend any time with individuals. Sometimes problem is patient pays from their pocket. They are not eligible for the universal health care or private insurance. How do they pay? And of course, that causes very limited access to newer treatments. For doctors who are working, they are mainly working, there's so much of pressure of patient, they do not have time for reading or research. Trained workforce may be less than what they should be. Lack of cancer registries, and people have to treat all sorts of tumors, not only breast cancer. So their time and luxury to develop kind of a research interest is also limited. Quite often, doctors leave the public health system. They are getting better paid in the private setup, so it's difficult to retain them. Similarly, trained breast radiologists who can read mammograms, and of course, accountability and transparency can be sometimes a problem. As you can see on the right side, these are the various treatment options. All of them may not be required for a specific individual, and also they may not be available, unfortunately, for that individual. So what are the solutions? Because we know the problems, what are we doing as far as getting good quality solutions to this? So people have tried shorter doses of some of the latest monoclonal antibodies and treatments that are available. They are trying generics. They are automating diagnosis. For example, Ki67 is a proliferation marker that is being automated so that we can actually do it relatively quickly and inexpensively. So there is a recent program which is now from the in various countries. We had two of these programs in India about 2 years ago, and it's called Choosing Wisely. So there is a lot of hype on new drugs, sometimes with very minimal and no survival benefit at a huge cost. So one has to be careful that not everything that is brand new is the best and works ideally for that individual. Sometimes the tried and trusted as well as reusing old drugs can work wonders. So we are trying various metronomic therapies, we are trying lower cost drugs, we are trying oral drugs as compared to intravenous, which may be feasible in lesser developed locations and countries and states. Similarly, we have a KWAT program, which is a trained task force to facilitate the cancer patient's journey. It's like a person you hold your hand to, is like a guide who would actually help the patient from entry into the hospital to follow up. So this is a new program, and we have a training course in the Tata Memorial Hospital, and I'm sure other hospitals are going to follow at the same time to help the individual. Because they tend to get lost when they reach a huge big hospital, especially if you are not very well educated and you're coming from a small place, it can be a serious problem. So these are some of the drug patient assistance programs, and most of the major companies of the world and local, whether it is Roche, Novartis, or Dr. Reddy's, I will not bother to take you also all the details. They are giving these drugs to individuals, some of the newer drugs and more expensive drugs at either cost or even sometimes free if the patients are eligible and the patient doctors are supporting them. The economics is a very major issue, as you can well understand. So the public sector infrastructure and cancer treatment facilities are sometimes inadequate. A lot of dependence on private setups, and as I mentioned, cancer treatment and diagnosis is sometimes the leading cause of catastrophic out-of-pocket expenditure, in which sometimes the individual has to beg, borrow, or steal, well, hopefully not steal, but maybe forced to sell their household jewelry or even sell their land and still land up without any major success as far as breast cancer treatment is concerned and cure is concerned. So the average out-of-pocket spending on inpatient is about 3 to 4 times in the private setup, and treatment for about 40% of cancer hospitalization is financed mainly through borrowing, sales of assets, and contributions, as I mentioned a little earlier. So this can be a very serious matter. So what do we do? The best thing would be, of course, that the person detects early and gets a better treatment. So that is really the importance of what I'll be talking in the next few minutes before I wrap up, as how can the country prevent this cancer if possible, ideally diagnose it early, and then give the best possible treatment in the given situation. So since early detection is the key, we suggest regular self-examination. Now, self-examination is no longer the ideal way of diagnosis, but it makes the individual knowledgeable and aware of her own breast. So if anything abnormal, she can go to a doctor. Most of the times, probably 9 out of 10, it will be something which is local, something which is benign, something which will go away. Or even if it doesn't go away, it won't cause any problems. However, that rare occasion where she requires further investigation, at least it should be available. Screening is done at the moment every 5 years, but we suggest every 2 years or every 1 year, depending on the situation. And I'll talk about that within a moment. We would love to spread awareness and let people know. October, as you know, the pink ribbon is celebrated all over the world as a breast cancer awareness month. We want to get the common man to talk about breast cancer and not treat it as a taboo. And we would also like to normalize the breast cancer. It does happen as age increases, as better diagnostic facilities are available and people seek help. It should not be a taboo, and that is the reason why people should not be prevented and should not hesitate from seeing their physician or the healthcare provider. So it is important to have a credible source, and we, at my previous institution, there is a lot of information available on the internet. There is a website called Cancer India, and that actually has an entire chapter. One of the more frequently tapped chapters and visited chapters is on breast cancer, and it talks about validated information. The other sites are from, for example, the CRUK site in the UK, and the US National Cancer Institution site called cancer.gov. A lot of information is available, which is credible. The ASCO, which is the American Society of Clinical Oncology, also has clear-cut guidelines of what should be and how the person should proceed if she is scared or has suspects she might have breast cancer. This is the National Cancer Grid, in which there are more than 200 cancer centers in India and research institutes, patient groups, and charities. They have recommendations for uniform standards. They develop trained human resources and collaborate between themselves, which is a very important resource which has come up in the last few years. Similarly, we have capacity building by various institutions and their meetings and awareness programs that are held. And there are global online courses which are also through the ECHO program. ECHO stands for Extension for Community Health Outcome program from the University of New Mexico. And many organizations in India are part of the Cancer ECHO, whether it is treatment or prevention or early diagnosis. And of course, we would like to have young advocates and to make sure there's adequate amount of advocacy and there's adequate coverage in the media, because media is a very important influencer. So about 5 years ago, or maybe 6 years ago, we had this operational framework for the management of common cancers, and it was preceded by a meeting. The proceedings of the meetings were actually published in one of the British journals called Lancet Oncology, in which the recommendations for screening and early diagnosis of cancers was laid out. And as you possibly know, the most common cancers are the cancer of the cervix, the breast, and the oral cavity. So the Prime Minister, way back in 2016, set a 3-month deadline, and that resulted in this blue operational framework, which is the bulwark and the mainstay of our attempts at early diagnosis and treatment. So for whatever research we do, whatever treatment is followed, it has to be cost effective, and more research is required for early detection and adequate and appropriate treatment for that individual. Lastly, I want to talk about palliative care, which is really looking at not only end-of-life care, but also making sure that the person who has received treatment remains as pain-free as possible and complications are fewer than what could be. So it's a discipline, is an emerging field in cancer in India. I think it is, and it should be an integral part of the management. However, there are lacunae and there's lack of trained personnel at the present moment. So this is how we are in the pandemic times. We are dealing with the support groups, and it is run by my friends, Dr. Sirohi, Dr. Nag, and her foundation, in which support is given to individuals regarding genetic testing, how to keep fit by exercising, what are the various walking and exercise groups, how do you deal with hot flushes, and what do you do for diet, and so on and so forth, which I think is a very important development that has happened over the last few years. So before I wind up, I think this is a very important slide, and which women normally, not only in India, but practically in every part of the world, form 50% of the population, and they take care of everything. Isn't it time that we take care of them? That is why breast cancer, unfortunately, is a rather neglected subject in the LMICs, and it is getting more important than what it used to be, but it really should be number one as far as our investment in terms of capacity building, awareness, in terms of early diagnosis and appropriate treatment and prevention is concerned. So with those words, I would like to thank you for your very kind attention. Another Time magazine cover, which came up a few years ago, and it talks about the new thinking on breast cancer. What are the smartest drugs that are there? What are the gentlest treatment with minimum side effects? And of course, how do you diagnose it? What are the latest on mammograms? And how do you handle it as far as the lower middle income countries are concerned? Emma, thank you so much for organizing this meeting, and I would really be very grateful to the Brunel University for having me here, and I would love to answer any questions which our audience may have. Thank you so much.
Thank you so much, Ravi. That was a really powerful and really important presentation. A lot of really information there for our students and for everyone attending. So thank you again. I'll turn to questions now, and please do continue to put them into the Q&A function there. But the first two questions we've had from the Q&A and the chat seem very connected, and they're around male breast cancer rates. So, for example, first question from Joy is, would any data be available for male breast cancer diagnosis? And relatedly, Francis, does male breast cancer follow similar trends as in women? So what would you say to that, Ravi?
Right. I think that's an excellent question. For paucity of time, I did not touch upon male breast cancers in India, but thank you for asking that question, first of all. Yes, male breast cancers are obviously far fewer than female breast cancers, maybe an extremely small percentage, but they do happen, and most people are not even aware that males can have breast cancer. As far as the trends are concerned, they are not really rising the same way as females, but I think it's appropriate for folks to know about it, to be aware, and also for a person who has a suspicion of male breast cancer to get the right diagnosis at the appropriate time, because here again, timing and the staging is extremely important. So if they are caught at the earliest stages, obviously the treatment is the best. So that is as far as the male breast cancer is concerned, and it's extremely important to know about it. But fortunately, I mean, that's the good news is that they are very, very few in number. The bad news is they still do come in the late stages and sometimes not with very good results.
Thank you, Ravi. A question from Adrian. Has there been success in other patriarchal conservative contexts to decrease stigma surrounding breast cancer, and how could these be specifically adapted in India?
Excellent question. There have been attempts, especially in Africa, because again, the same problems do happen there in other parts of Asia as well, to increase awareness, not only for breast cancer in males and the elders of the family who are quite often more dominating in the rural and semi-urban areas of the country, but I'm afraid things haven't really changed a lot. And we had a very similar concern when we talked about cervical cancer, which is the number 2 cancer for women in India. There are better diagnostic facilities, and the good news is that the number of cervical cancers is going down in India, just like many other developed countries where cervical cancer was number 1, and gradually the cervical cancer went down. Unfortunately, as a seesaw, the breast cancers go up. So we are really seeing, as we are going through the epidemiological transition and the financial worth of people as well as lifestyles are really changing very fast, that we are seeing breast cancer is going up. But come back to the question of how to change this conservative context. I think the only way to do it is education and awareness. It is happening, especially in the cities where things weren't very different from the rural areas till about a decade or 2 decades ago. Things are changing. People are getting more and more comfortable with taking their spouse or letting the spouse go on their own or with friends to see doctors. That same sort of very close society is no longer there. And as girls are being educated in the rural and semi-urban areas, their own awareness levels are going down. The fact that many, till a few years ago, there weren't too many women in the workforce, as they're increasing in certain areas, even up to 50% or close, women of all workers are females in certain professions, not everywhere. So as their awareness grows, their own feeling uh, of self-worth and independence and mobility, as you can, if you've been to India or at least seen a few pictures, sometimes up to 50% of commuters on the road, either driving their motorcycle, their scooters or cars, are females. So with increasing mobility, increasing financial independence, higher awareness, as well as the self-found confidence, things are changing. However, to be absolutely honest, they are not changing as fast where we doctors would like it to change. But yes, change is in the air, as they say.
Thanks, Ravi. A related question, just when we're talking about awareness from PAV. So is this, or breast cancer, talked about in schools?
Not as much as it should be. Again, the school curriculum are changing. So unfortunately, cancer doesn't really figure very high. And as you can well agree with me, when you're all of 15 or 16 years of age, cancer is something that is very much somewhere behind, happen only to the older generation. And but infections we are talked about, but I don't think, to the best of my knowledge, breast cancer awareness is talked about in schools. However, there is a silver lining, as usual. A lot of role models, including celebrities and film stars, when they have breast cancer, especially in the last 5 to 10 years, they are talking about the disease, that I had breast cancer and I got treatment, I'm fine now. So that has actually changed. A lot of ambassadors for breast cancer has come up. And now by the celebration of occasions like the World Cancer Day, you have rallies, you have marathons, you have so many awareness campaigns. Again, predominantly in the cities, not so much in the heartland of the countries. Things are changing. But I really wish that we could have even part of a chapter in a school where all the teachers would talk about things like breast cancer and to remove the taboo. I wish we had more of that. And maybe in the years to come, things will change.
Thank you. And Soraya has a question, I guess, about the epidemiology of breast cancer. So does oral contraception or breastfeeding have any risk relationship in India as it does in other parts of the world?
Yeah, thank you, Soraya. I think both, they're two separate questions, though they are related. So nowadays, the oral contraceptive pills are fairly low dose. And unlike the high dose estrogen pills that were in prevalence maybe a couple of decades ago, there has been no correlation between oral contraceptives and breast cancer as of today. So that is the same all over the world. Lot of people in India, they, as far as contraception is concerned, they use either male contraceptives like the condoms or the copper T, which is insertable device in the vagina and the cervix. That is actually a more common thing, but people do use oral contraceptives. It's not that's not used. But to the best of our knowledge, oral contraceptives that are available today are not related to breast cancer. And the same is true for anywhere. The other question was breastfeeding. I think that's an extremely important point, and I very briefly touched upon it in my presentation. One of the reasons that is happening, the change, and one of the reasons why we feel the breast cancers are going up in the lower middle income countries is that the age of marriage, that is, it used to be the late teens and early 20s, that has actually gone. Many people, since they're working, they're looking at the career like anywhere else in the world. So if girls are getting married late by 25, 30, 35, and so on, like anywhere else in the developed world. So that age of marriage is changing, of course, not everywhere, but in many parts of the country. When they're marrying late, the number of kids that they are deciding to have is also less. I mean, I think the average fertility now is little more than 2.3 kids per lady, although in many other parts of the world it is actually far less. Sometimes it is one or even less than one, for example, in Scandinavia or Japan. But in many parts of Asia, it was used to be, and in India as well, used to be up to 4 or 5 kids per lady. So you can imagine if you are going to breastfeed 4 or 5 kids, the amount of time you're going to be lactating is much higher. So that has come down to a little over 2. So number of kids is less, and quite often, especially women folk who are in full-time occupations or in the higher echelons of the society, there are a number of months or years the kids are being breastfed is much less than what it used to be. Again, following the rest of the trends in the world. So when you have lesser kids, you are producing kids at the higher age and breastfeeding less, the chances of developing breast cancer are obviously lower. Higher rather, sorry.
And another question, I guess, related again to epidemiology from Mohammed. So in my area back in Pakistan, breast and other types of cancers have increased since the start of excavation of land for extraction of uranium, owing to pollution of subsoil water streams. What do you suggest to curtail the increasing rates of cancer when uranium is a rich source of energy?
That's a googly, and it's a very interesting question. To the best of my knowledge, pollution of subsoil water by anything, whether it's uranium or whatever, does not result in increase in breast cancer. But I'll be because the amount of uranium which may be there is usually much less than what is the toxic dose. But I must admit to it that I am not aware of any such issue in India, at least. There are high levels of radiation on the west coast of the country, which is Kerala. And there they have found a higher prevalence of thyroid cancer. But to the best of my knowledge, such radiation, which is a subsoil radiation or due to excavation, is not responsible for breast cancer. Having said that, when you talk about the Second World War and you talk about places where the atomic bomb was or Nagasaki or Hiroshima, there they did find certain cancers did go up. but there was huge doses of radiation. They were not the subsoil radiation. So, Mohammed, thank you for asking me that. But to the best of my knowledge, that is not entirely correct. But I may be wrong. So in case I find something, I'll get back to you on that. So thank you for asking the question.
It's a really good question. And Francis has a related question on incidence. So are there comparisons between the situation in India compared with the Asian population living in the UK?
Excellent question. I was hoping somebody asked that question. I didn't touch upon it because of paucity of time. But yes, when you look at the Asian population in the UK or in the US, and there is a large diaspora. So what they have found is recently a few papers were released on that in the first generation immigrants, the risk really remains by and large the same. But as folks adjust to the local climate, the local food and customs, the risk actually becomes higher than for example, if they have twins who are living in Asia and haven't moved to the UK or US. And I think it could be related to diet and it could be related to exercise. One thing which I may or may not have focused on specifically in the presentation was the relationship between obesity, that is weight, and breast cancer. I think I mentioned in the passing that, post-menopausal, that is after the menopause, the lady has a higher chance of developing breast cancer if it is obese, or if she is obese. And unfortunately, the number of obese in the West, especially in the US, practically in some communities, up to 30% of women are obese. And unfortunately, in South Asia as well, because of people adopting a lot of the same kind of lifestyle of having junk food. By junk food, I don't only mean Western junk food. India and South Asia also has a good amount of junk food around, and decrease in daily exercise and using all the modern conveniences, or even the work at home they used to do by washing the clothes. Nearly every house in the city would have a washing machine and the microwaves and so on and so forth. So the amount of effort that they used to do while cooking or cleaning or the daily chores of household, the amount of effort has gone down tremendously. And unhealthy eating habits, lack of exercise, and generally not really living the same kind of a healthy lifestyle that they used to. So that is probably some of the reasons why it has gone up. And the situation in the UK and India are not really very different, at least in a segment of people. So that is what I would like to tell Francis, that thank you for asking that question. And I think it's extremely important. But geographical oncology of people, living in different areas or moving from one part of the world to another is a field which is very fascinating. And a lot of institutions in the country, in India, and I'm sure in the UK, who are specializing in that area.
Thank you, Ravi. And another question from Deborah this time. Would the Indian government be able any day to provide free cancer treatment like Germany?
Well, I would optimistically always say yes. However, one also has to look at the size of the country, which is kind of about more than 10 to 20%, 10 to 20 per times the population of the country and the amount of money available. These are the three major constraints. However, there is always two sides of the coin. So we were very sieged in the government as what we can do, at least to provide free cancer treatment to the poorest of the poor. And last year, that is 2019-20, the government released a program, which is the largest universal healthcare program in the world, where the bottom 30% of the people who were below a certain amount of income as per their income proof, which is known as the poverty line, were given free insurance, not only for cancer, but also for all diseases up to an amount of 500,000 rupees per family per year. So that has actually it is just taking off. It's early days, but we have a dashboard, which is called the Ayushman Bharat, which Bharat means India. And that talks about the healthy India, and that has been rolled out. Unfortunately, because of the COVID, things have become a little slower than what they should be, but already about more than 500,000 individuals have benefited. And we can actually look at the website there, and they will tell us what is the amount of money that was distributed, what were the diseases they were distributed for. And you'll be happy to know that as far as cancer is concerned, which of course takes the largest chunk of money, because all these things are expensive, breast cancer is probably the largest number which have taken the amount of money. And that has changed the scenario. We are nowhere near where the national health scheme is, we're nowhere near where Germany is, but we are a lot better off than we were, say, even 5 years ago. And of course, private insurance is also taken up to a large extent. And most of this Ayushman Bharat is actually co-paid by the private insurance as well. So the treatment is available not only in government hospitals, but also in the nearly 60 to 70% of all healthcare in India is in the private hands. So that is taking an equal part as far as giving the best treatment possible for that individual. However, having said that, there are areas where we are not really as good as where we should be, but attempts are on. Thank you for asking that question, Debraj.
Thanks, Ravi. And in the chat, Genevieve has said a few times kind of that prevention is really important and that needs to come to the top of the priority list in terms of breast cancer. So I wondered if we could ask the question, so what are your views on the most effective and important prevention strategies that can be used in India relating to breast cancer?
Well, that's again an important question. Thank you for reminding me, Emma. Unfortunately, most people with breast cancer, there's not a lot you can do to prevent it. So unlike oral cancer, where we can avoid tobacco, or cervical cancer, where we can take the vaccine and go for regular screenings. Here, what we generally tell people is not to delay the marriage too much. Have kids as early as possible and breastfeed them at least for a year. At the same time, we also tell them to avoid putting on weight, avoid alcohol and tobacco, and at the same time, be very observant as far as any early signs of breast cancer is concerned. So that is one of that. The first part was primary prevention. The second part is secondary prevention, in which we talk about early diagnosis. So aside from clinical breast examination, as a matter of fact, just yesterday, there was a paper released in the British Medical Journal, the BMJ, which talks about a 20-year span of time where a study was done from our colleagues at the Tata Memorial Hospital with Dr. Mitra and his colleagues. And he found that doing a simple clinical examination, which does not require high technology, resulted in a decrease in mortality by 15% in women age 50 and more. And this is done every 2 years, just a simple examination, no mammography done at the screening stages. So go to your doctor, get a clinical examination done every 2 years, and ideally, especially if you are over the age of 45 or 50. And there is a government program, I alluded to it briefly as far as the operational framework was concerned, in which all women over the age of 30, as a matter of fact, not only 50, we wanted to start as early as possible, would be screened for cervical and breast cancer. And that's already been rolled out in more than 200 districts. However, this thing is still underway, and we are hoping another 5 to 10 years' time, it'll become universal. So these are the sort of specific areas when we talk about primary prevention, of course, lifestyle. Secondary prevention, talk about early diagnosis. And more setups have the facility for a mammography, and people are getting more aware, and quite often the insurance covers the mammogram, but usually that is delayed till the lady is 40 and more.
Thank you. And a question from William in the chat. You suggested that there were a number of costly and not proven drugs available. Are there centralized mechanisms for controlling their usage or formally evaluating their cost effectiveness?
Very appropriate point, because there are so many, so to say, myths and so many newer drugs that are available, not only in India, but practically everywhere. And most of them are available in India. Some of them have got clearance from the FDA or Drug Controller of India. Some are still experimental. So the Control mechanism is specifically where they do not get clearance from the drug controller until there is proof for that. However, having said that, the claims, especially our American colleagues and drug companies based in the West, are very aggressive in marketing the latest and so-called the best, whether it is the best or not, and does the overall survival or even symptom-free survival for a few months or a few years, is that commensurate with the so-called advantage of survival or quality of life? That is a difficult situation. I know in the UK, you have a very good system from the NICE, which actually gives you guidelines. Only in case they're approved by the NICE, then the National Health Scheme will pay for it. But they are available for, if you have the money and you have the right connections, you can actually get nearly every medication. So there are systems, there are checks and counter checks available. However, they could be a lot better. And that is why with the National Cancer Grid or with the Indian Council of Medical Research, which I work for, they have guidelines that this is the minimum and this is the standard operating protocol as far as treatment guidelines are concerned. Ideally, we would like you to stick to that and not go for extremely expensive and sometimes unproven therapies just because they are the latest and the most hyped about, may not be that they are the best for you. That's a very important question. Thank you for asking that.
So thank you all very much for joining, and most of all, thank you, Ravi, for a really, really interesting talk that has got a lot of conversation going. So thank you very much, and thank you all for joining, and we look forward to hopefully seeing you next week.
Thank you for having me over. I really enjoyed giving this talk. I hope listeners enjoyed listening, and I was really very enthused by the response that we are getting, and some very interesting and very appropriate questions were asked. I would love to thank you for this. Bye-bye.